on a little bit late. So thank you. And I can just see Jackie Pete's on there as well. So it's great. So we've got people from interstate as well. Excellent. So welcome everybody this afternoon to this fourth masterclass. As you can see, we have presenters Denise, Edgar, Linda Deys and Andrew Murray, all of whom are currently doing their PhDs. So this is just an added bonus for them to be asked to present for us. So it's so we welcome you all, and we are here to support you in your presentation. And if people do have questions, I would ask if they just pop them in the chat box. That would be really great, because Barb's going to moderate some questions at the end of each of the short presentations, which will probably go for around 10 or 11 minutes each. Okay, so without further ado, I'd ask to be whoever's organising the slides to go to the next slide. Okay, so in this series of masterclasses, we have been looking at different aspects of person-centred practice, and today is no different. So each of the students that are presenting their work from the perspective of their philosophical perspective, much of which is either related to person-centredness or in Linda's case, to women-centred care. I've got it right, Linda. Didn't say it was person-centred, it's women-centred care. Yep. So we're going to see different aspects of how they are working within the space and drawing out things. And you'll see from the three topic areas that we're covering today that it's really nice to see that breadth spread across the whole kind of conceptualization of person-centeredness, so that people are doing different things in different spaces with it. So it's not that you need to kind of encompass the whole thing. You can take aspects of person-centered framework and actually look at how that relates to your study. So without further ado, I'm going to introduce the first person to speak today, and that's going to be Denise. I will put a little bit of a timer on you, Denise, and I will let you know when you've only got, when you get to that 9-10 minute mark. I'll just pop up a thing in the chat to tell you if that's okay.
Yeah.
So over to you.
Thank you very much. So today I'm actually going to talk about my PhD and with the University of Wollongong, with my Val being one of my supervisors and Tracy Moroney. And I just want to acknowledge them as person-centred supervisors, because when you're doing person-centred PhDs, it's really important to surround yourself with people who actually live those values. I'm also a nurse manager at ISHLHD, but I'm also a wife, a grandmother, a sister and a friend. So I'm not just my PhD, I'm actually a person. And I forgot to say that I'm a mother, but I think I've bumped my kids off for being a grandmother. So what I'm doing is integrating the person-centred practice framework actually into my research, into clinical supervision. And that's what I'm going to talk to you about today. So I'll talk a little bit about the background to how this actually came about, because taking on a PhD is a big commitment to you. How I applied the person-centred theory to my study, and how I use that theory in practice as well, in the evaluation, sorry. So just going back to defining person-centred practice, so we saw the framework, but we know it's an approach, it's about relationships, it's about values that underpin how we work with people. It's about respect, mutual respect, really getting to understand people, but we need to have cultures that actually allow that to happen. And we want all of this so people feel quite empowered to develop their practice. So clinical supervision is this protected time that you get to reflect on your clinical practice. And with something so person-centred, it's difficult to call it clinical supervision because it sounds quite directive. So we actually call our programme the CARE programme. So connecting, appreciating, reflecting and empowerment of nurses and midwives through reflection and clinical supervision. So just a bit of background to this. In 2017, a family and child health nurse said to me, as a team, we've become more person-centred since taking supervision. And I went away and really thought about that. So she said person-centered, not only to their clients, but also to each other. And that was quite a profound statement to me. And I thought, what had I done? What did I do that captured that? And that was about helping them reflect through a person-centered lens. We also know McCormack talks and McCann's talk about the environment, that staff also need to feel person-centeredness as well. So I kind of feel like I kind of brought that into supervision. And then I read a study recently, and it was talking about embedding person-centered practice in every healthcare strategy. That's the way we'll make it move forward. So I feel like I kind of do all of those things, but how did I kind of capture that to support other people to do it as well? So my research question following that profound statement was, can clinical supervision underpinned by the person-centered practice framework actually enhance person-centeredness? Now, COVID came along and I had to take a pragmatic approach to my study, and I did it in new graduates during COVID, and most people would have run 100 miles trying to do any research in COVID. It's a mixed method study looking at both quantitative and qualitative, and it was done with, not on, 103 new graduates in 2020. So the training itself, I had to find supervisors, and I found, I think there was like 10 people from the University of Wollongong who offered to support this, which is absolutely fabulous because they knew the framework and they knew reflective practice. And I had supervisors that had also trained here in Wollongong in ISHLHD. So what we did is we did 2 sets of training. So the first one was about applying the person-centered practice framework to you as a person, as a supervisor. And if you kind of look, say maybe even just at the professionally competent construct, that was about how can you maintain and develop your competence as a clinical supervisor and a person-centered one. Do you know your own values and beliefs? And do you know your own self? Because they're really strong things that underpin being a really person-centered clinical supervisor. So on top of that, we actually did supervision for supervisors using the same processes as we were going to do with the new graduates. So the second workshop was about how do you raise awareness of person-centeredness within your clinical supervision sessions or your care sessions. And so most of the supervisors would have used a Gibbs reflective framework. So they used the framework, but through the lens of the person-centered practice framework. So for example, if I had a medication error, that would probably come under professional competence. But if I had an issue with one of the staff members, that might come under the construct of environment. And so they were also just asked to help the new graduates come up with a solution that was person-centered, or to find some way forward that was person-centered. So on top of that, I also used the person-centered practice framework as my evaluation framework. My timer's gone off, so you'll have to keep me right, Val. And I used the person-centered practice inventory, and it actually maps across to 3 constructs in the person-centered framework: the person-centered processes in the middle, the environment, and the prerequisites. So the new grads completed this pre and post, and as did the supervisors. So this is just an example of what this looks like. So this is professional competence, if you remember that in the constructs and prerequisites. It talks about the knowledge, skills and attributes of the practitioner to negotiate care options and effective and provide holistic care. So these are the 3 questions that sit under professional competence. And I'm not really going to go into the results today because that's not what this is about, but just so you can kind of see how the evaluation maps across to the person-centered framework as well. Again, this is about knowing yourself, which is a really important aspect of being a person-centered practitioner. I take time to explore why I react the way I do in certain situations. I use reflection to check out my actions, and they are consistent in the ways of being. If I just show you this one though, that the end bar is actually people who came to supervision more than 5 times. So there were regular goers, And their actually scores have been higher all the way across all the prerequisites. So I think that's an important finding, not for today, but for another day. The other thing I did was I took some quotes. I've put some quotes up here. When I asked the new graduates, what did you get out of this? What did you take away that was practical for you? I got some lovely comments, and I'm in the middle of theming that just now. But if we look at things like, we had different ideas of how you could make it more personalised and person-centred. This was an aspect that they had, one of the groups had a topic of end-of-life care. One of the new grads talked about, they're not just a condition or a bed number. And that just, you know, when someone says that to you in a new grad and they're so busy with the busyness and the task, that's just so lovely. And they just talked about the little things that they took away to put in their practice to make it a bit more person-centred. So reflecting on nursing using the lens of person-centredness, they really talked about how the framework supported their thinking. And they talked about their person-centred facilitator. Like in this quote, I think she kind of adopted a person-centred approach to us as well, which was really nice. And that was the whole point of the first workshop. Like, how do you take person-centredness and take it into your facilitation and into the supervision? So just in terms, just to summarise where I'm at the moment, I think the person-centred practice framework really supported person-centred conversations, and there's evidence to show that learning has been applied to practice and evidence of person-centred moments being captured. The person-centred facilitator, by engaging in, is really role modelling person-centred practice as well, and they really created person-centred cultures within those care environments. And I think my last kind of point is that new graduates are our future leaders. So investing in this kind of work, if person-centredness is the way forward and the way we want them to be, and they're getting it in university, we need to be able to continue that when they come into the workplace. So I just wanted to say thank you, just gave you a little bit of a snippet about how I was using the person-centred framework within my PhD study. Thank you.
Well, Denise, thank you very much for that, and perfect, impeccable timekeeping. You had the summary slide up as I was about to say it's a minute ago, so no pressure for the other two.
No pressure.
And I have to say she didn't learn it from me, because I'm pretty bad at it. So you may have some questions that you want to ask Denise, as Sue has said, pop them into the question, the chat box, because we will get to them. We're going to do 3 quick presentations, and then we'll get back to the questions.
Linda, just give me a nod when you want me to change the slide.
Oh, okay, no worries.
Okay? Excellent.
Hopefully I don't have a nod out of place or something.
Well, that was excellent. Thank you, Denise. And we'll move on now to Linda. And again, I'll give you the 1-minute warning at the end should you need it, Linda. And Linda Deys is a CMC lactation support nurse at ISHLHD, and also a PhD candidate, and she's going to share her experience of her research with us today. So over to you, Linda.
Thanks, Val, and thanks, Denise. Yes, so I'm talking about from a midwife's point of view, so that this is looking at a woman-centred approach. So I'm looking at how we can value women in maternity care, particularly birthing care, using a woman-centred approach to improve their birth experience. And my supervisors are Val and Charlotte as well. So woman-centred care, I want to talk to that a little bit more and why, as a midwife, we talk about woman-centred care. So this is a quote from the Pregnancy Care Guidelines, Department of Health, so Australian government. Woman-centred care focuses on the woman's unique needs, expectations and aspirations, recognises her right to self-determination in terms of choice, control and continuity of care, addresses her social, emotional, physical, psychological, spiritual and cultural needs and expectations, which is similar to parent-centred care, patient-centred care as well. It also acknowledges that a woman and her unborn baby do not exist independently, and that's a really important part, that they are one being, and that's part of her social and emotional environment, and incorporates this understanding in the assessment and provision of health care. Okay, thanks, Denise. So using the term woman-centered care is really fundamental to midwifery care. So it's underpinning the philosophy of midwifery, and this is with our professional bodies, our ethical statements and care standards. So just some examples over on the side there, you know, that are both Australian, like APRA, pregnancy care guidelines. We've got our international codes for both midwives and through ICM as well. It's individualising care and empowering women as being the main stakeholders in their own care. Okay. So this, Nikki Leap has written a lot about woman-centred care, particularly defining the difference between saying woman-centred and women-centred. And this is a quote from one of her papers. So it focuses on the individual needs, aspirations and expectations rather than the needs of the institution or professionals, which is really important. Recognises the needs for women to have choice, control and continuity, and known caregivers. Encompasses the needs of the baby, the woman's family and other people important to the woman, and that is grouped under that title, woman-centred care. So it's all of those that the woman says are important to her. It follows the woman across the interface of community and acute care settings, and it addresses those social, emotional, physical, psychological, spiritual, cultural needs and expectations. And it's recognising the woman as being the expert in her own care. Next slide, please. And the distinction between that woman-centred rather than women-centred care, and I think if you think about with patient-centred, we don't talk about people-centred care, it's always about the person. So shifting that focus onto the individual woman rather than the health professionals and the service. So as a professional, I may be women-centred, but that's about a whole group of, you know, people that I care for. This is focusing on the woman that is in front of me at this moment. And from that midwife perspective, it's a different care paradigm. So we talk about woman rather than patient because mostly we're working in a wellness framework and definitely with those feminist underpinnings, which is where my research has really come into it. Most women having babies are just doing another step in their life. This isn't a sick procedure for them, whereas patient-centred is really talking about people who are ill, needing to be in hospital for care for those reasons. Thank you. So feminism. So we all need to put our hands up for the ladies in the room. Can you click again, please? So yeah, in modern medicine, the pregnant and the birthing woman is expected to be a passive patient. And this is a really big part of feminism and birth. Women are supposed to be well behaved, do as they're told, and yeah, just get out of there as soon as I can. Next click, thank you. And you know, there's been a lot about birth trauma in the last week on social media and the media, and a lot of women come out of having a baby feeling completely traumatised, both physically and emotionally, even when they're allowed to do some of the things they want. And I have put allowed in inverted commas there because that is just so much a part of not being woman-centred, allowing somebody to do that. We often talk about we're going into consent a woman, where women are consented rather than them giving consent. So we're ticking a box, but we're not letting women make choice. We're not giving them the right to decline if they want to. And this gets told to women a lot, but at least the baby's healthy. So that woman-centred care is really approaching, it's about autonomy, power, control and choice. Next slide, thank you. So my research is titled Where's My Baby? What is the maternal experience of separating well mothers and babies at caesarean section birth? Next slide. So I'm using a feminist phenomenology methodology, so completely qualitative. I've done 15 unstructured interviews, which have been completed and transcribed. I'm doing data analysis at the moment using a modified Van Kam approach. And I'm using a theoretical framework of two feminist birth theories, the birth territory and childbirth as a rite of passage. So birth territory is really about, you know, the terrain, the place that a woman is having her baby, and the jurisdiction, so who has power and control in that room. So it was developed to describe and predict birth outcomes based on the woman's experience through that physical birthing environment and whether she felt like she was in control or not. And a caesarean section birth in particular is often a place associated with fear. Women don't feel safe, but it's still, midwives particularly are in a position to be able to still keep the woman at the centre of the care and return some of the power and control to her, which can influence the birth experience. Next slide. Childbirth is a Rite of Passage is by Rachel Reed. So, and it's really looking about the balance between the rites of passage of a woman having a baby and also the rites of protection as well. It describes the birth journey in various stages, including how that works with a surgical birth such as a caesarean. In that environment of safe and respectful care, the midwife advocating for the woman, supporting her no matter the kind of birth that she has. And it really highlights that a positive and empowering birth is associated more with how a woman is treated more than how she births. We know that caesarean sections increase negative birth experience. Women have less control, both physically and emotionally. They can't get up and run out of the room when somebody takes their baby. And that's particularly what I've been looking at, that, you know, the value women place on having their babies with them closely. A little bit of a plug for the paper that we've already published on the literature review, looking at if you keep mothers and babies together, what is the birth experience like? And women really strongly desire to be able to see, hold and feed their babies, and they don't want somebody taking them away from them. And it's really about providing options and choices for women. So this is the goal from my research, is that, you know, we'll be able to get all women given the opportunity, if they're both, they and their baby are well, that they'll have immediate and uninterrupted skin to skin as they're demanding, and that we're keeping the woman at the centre of her birthing care, because this is really about her and her baby. And this is a little bit of a photo what skin to skin can look like at a caesarean section. Not quite so simple if there's any midwives in the room, but thinking about, you know, keeping the focus of the mother with her baby and not taking the baby away and medicalising it more. And that's all for me. Thank you.
Thank you, Linda. I didn't even get to the minute. You did it in 9 minutes. I'm feeling like left out here. I've got no buzzers.
I was scared.
So thank you for that. And I think you can see between Denise's talk and Linda's talk how they've brought their own self and their experience into their research question and really connected up that to their kind of desires, their philosophical bent, if you like. So that's been really great. So without further ado, I've got our last speaker of the day, and I know some of you have been popping comments and questions in for the previous two speakers, so keep doing that. And I'm now going to hand over to Andrew Murray, and he's going to talk about his study, which is, again, a little bit different. So it's quite nice. We've had to do, we've had different kind of contexts for each of these studies. So over to you, Andrew.
Yeah,
and
thanks,
I've got the timer on you.
Okay, yeah, I might be able to take up a little bit of that time that Linda has offered me. Yeah, I'm going to talk about the Good Life programme, which is a staff development programme comprised of 5 workshop days combined with facilitated clinical practice development. It's the topic of my PhD. We're using a realist inquiry approach. The programme intends to equip nurses with the inter and intrapersonal resources to influence the care context towards a more personalised form of rehabilitation and contribute to the evidence base for coaching as a rehab nursing practice. The programme was co-designed and delivered with consumers using realist research methods to improve its iterations. Next slide. So what's nursing in rehab all about? It's really nurses use coaching within rehabilitation nursing as an area of practice where they can demonstrate their therapeutic contribution to rehab outcomes. Nurses tacitly use coaching as they gradually reduce the level of assistance they provide to patients each day, encouraging the patient to be as independent as possible. They provide physical and emotional support, stepping in when the patient gets tired and frustrated, encouraging encouraging them to persevere when things get tough and helping them to see that there is hope for the future. While nurse coaching is considered a core competency by our Rehab Nurse Association, the practice operates within a very limited evidence base and functions without direct guidance on implementing coaching within a person-centered framework. Next slide. And therefore, I undertook a review of inpatient nurse rehab coaching. The literature was undertaken to discover the constituents of rehab nurse coaching and understand what contextual conditions influence its practice. The review found that the role of rehab nursing was considered important but unclear and is often seen as operating in the service of rather than a part of the multidisciplinary team. Nurse coaching contributes to the rehabilitative milieu nurses co-create with consumers, but is also constrained by the nurse's position within the archetypal professional hierarchy. Despite this, nurse coaching is considered an inherent aspect of nursing care, and we found that there were two forms of coaching identified in the literature. Generic coaching is a transactional, tough love kind of care that is increasingly seen as outdated and unjustified, particularly in specialty settings such as stroke, spinal cord and brain injury rehab, where long-term disability is an inevitability. Here, generic coaching can be seen as a blunt instrument that may harm the care relationship. In contrast, personalised nurse coaching is a relational form of rehabilitation that consumers prefer. Consumers report that hope is a particularly fragile feature of recovery, and the attributes and skills required for personalised nurse coaching are complex and responsive to the needs of a person coming to terms with long-term disability. Rehab nurses are not properly equipped to deal with the emotional work or specifically trained with the relational skills needed to work in specialist areas such as stroke and spinal injury, and the literature supports the need to develop specifically designed learning and development programs to meet the needs of clinicians and consumers in providing person-centered rehab. Next slide. So, realist evaluation. The realist approach to research aims to accumulate knowledge by refining program theories across a sector, policy or practice, rather than simply providing evidence of the effects of an individual intervention on predefined outcomes. Programs are considered theories incarnate, and the research cycle starts with an initial idea of what is intended to work and ends with a refined theory based on evidence directed at the development of context, mechanism, outcome configurations, which we'll show shortly.
Sorry.
The role of the researcher is to explain what it is about the program that is expected to generate the change in outcome, represented by a theory of change or program theory. Yeah, next slide.
Sorry.
That's all right, pretty much the same thing. So realist evaluation has been chosen as appropriate for the research as in the explanatory logic of inquiry that doesn't just examine if an intervention has worked classically. It looks for the metaphorical black box of rehabilitation, asking what is at the heart of person-centered rehab programs and trying to understand what it is about rehab programs that make them work in the way that they do now and how to transform rehab programs to better reflect the perspectives of people with disability, creating the necessary conditions for positive care experiences and outcomes for both service users and providers. The realist philosophy is especially suited to this program as aspects of the program's success are considered to be explicitly context dependent, such as the nurse's position within the professional hierarchy. And context is king, and outcomes depend on mechanisms interacting with the real-world complexity of multidisciplinary rehab. I was tempted to say context is king and mechanisms is queen and outcomes are their offspring, but I think that was too royalist or gender specific, but there's definitely a relationship between context, mechanism and outcome. And the realist research aligns with complex systems theory, which programs are embedded in complex systems where outcomes are emergent properties of the whole system. It's interesting because within rehab, most of the research is done within the biomedical framework using reductionist research, despite the WHO biopsychosocial model of health, function and disability. Programs are not mechanisms themselves, it's the provision of resources that influence the participants' decision-making that causes the outcomes to be emerged and enabled or constrained by the specifics of the context. Next slide. So, substantive positive psychology, coaching, and adult learning and development theories inform the program development, design, and delivery. As a counter to the pity and paternalism that people with disability continue to encounter, the concept of self-determination provides psychological theory and moral principles correlated with positive health and well-being outcomes that are highly relevant to disability and rehabilitation. Consumers value care relationships that engender hope and appreciate staff who help envision positive futures adapting to life with disability. While staff are considered non-caring when they repeatedly stifle hope, are authoritarian, bossy and paternalistic. Hope theory provides a countermeasure to the prevailing context in which clinicians fear fueling false hope in conditions such as stroke and spinal injury. It explains how hope can be sustained after acquired disability, when we can help explore multiple pathways to the same goal and support a sense of agency, offering a solution-focused approach to making sense and finding meaning when living with disability. Next slide. The initial program theory consists of the aspects of the workshop program that were designed to challenge participants' current frame of reference towards disability and rehab. Participants learn evidence-based skills, thoughts and actions that align with positive health and well-being outcomes, reflecting the maxim that when you look after yourself, you're more able to look after others. Through the element of consumer co-production, combined with experiential learning, we cultivated a safe space in which clients, clinicians and consumers with lived experience of disability rehab could learn with and from each other. The presence made exploring hope and positive care experiences real and often emotionally challenging. This helped generate many of the clinical commitments participants made in response to stories about impersonal, sometimes dehumanizing and undignified aspects of hospitalization that consumers had experienced and that we may have unintentionally perpetuated as clinicians. By enabling participants to cultivate mindfulness, self-compassion and wellness skills, they're more able to be open to learning new ways about thinking about disability and being more able to effectively coach and partner with clients. Advanced metacognitive reasoning skills are developed and integrated with the latest evidence on human behavior and complex systems to enable nurses to engage in and lead the changes needed to translate knowledge into practice and transform the care context. And realist evaluation seeks to develop and refine theory of what works in the real world in order to improve future programs. Next slide. How am I doing for time? It's the job of the realist researcher to devise a set of methods to test context, mechanism, outcome configurations that explain how resources can activate reasoning and responses within people and groups of people for whom the program is intended to make a difference. This necessitates collecting a range of data beyond the program inputs and processes, examining the specifics of the program theory and context that might impact outcomes while specifying and measuring the mechanisms that account for the proposed changes. This requires a mixed set of methods and measures. Realist research also encourages using local data to frame the context, especially the reuse of primary data to describe program effects on the context and track the changes that may have taken effect. This is contrary to the traditional research design, when the emergent and iterative aspects of real-world programs are included rather than controlled for by the realist researcher. In our case, we designed a pre-post test of the program content, the intended outcomes related to coaching, hope, positivity, mindfulness, self-reflection and compassion amongst others, followed by a period of program consolidation where we're then able to reinterrogate local nurse engagement survey data and comparing the target units with a representative sample of nurses from rehab units across the local district. And the final method of realist research is expected to be realist interviews, in which the development of the refined program theories are discussed with key informants in search of explanatory program mechanisms that may or may not have fired in this context and uncover portable program components that may be applicable to other contexts. Next slide. So some results. I'll just whip through the results and come to our conclusion. Following the reconfiguration into classic context mechanism and outcome heuristics, the final product is refinement of the initial program theory using realist evaluation. These slides suggest that the metacognitive skills developed has enabled advancements in solution focus and strength-based coaching. Participants were more hopeful and experienced less negativity following the program, and there were significant changes in mindfulness measures that are associated with improved self-reflection, mindful presence, and a heightened awareness of oneself and others. There were statistically significant improvements seen in work-related measures of confidence, proactivity, and engagement, which were prerequisites for applying knowledge and clinical skills in the new context. Next slide. The re-examination of the nurse engagement survey showed that the post-workshop changes had influenced the care context. The nurse engagement analysis showed a significant greater sense of adult educational support and improved skill sets expected for their roles compared to other rehab units in the district. They also reported significant fewer work demands, less intention to leave, and burnout compared to other rehab units across the district. In relation to teamwork, nurses reported significantly greater team engagement, productivity, less task and interpersonal conflicts, and more conflict management than other rehab nurses. Finally, the survey also showed significant greater transformational leadership and growth-based leadership styles. It was quite a revelation actually when we interrogated the nurse engagement survey relative to a comparator group. Pretty much across the board there was improvements, but there's a whole heap of significant differences. Last slide. So the major themes from interviews spoke of participants' sustained growth and personal development. Participants described how the application of personalised approach is underpinned by coaching and mindfulness practices. There was a shift in meaning making and advances in moral reasoning that were recounted in interviews and described in the real-world clinical experiences with consumers. This demonstrated that the Good Life Programme initial programme theory had been reflected in nurses' practice, and this was evidenced by personal reports of collaborative partnerships built on mutual trust and respect. The interviews and surveys will contribute to the refinement of the programme theory in a form of realist evaluation, which is watch this space. Done. Thank you to my superb supervisors and the influence of Nicholas Yu and Sue Sims in the development and continuous of the initial and subsequent programs. The Spinal Cord Injuries Australia Peer Support Group were the initial set of consumers that informed the design and delivery, and subsequently we had some other recent patients who had had a stroke and had attended our rehab unit as the contributors as consumer participants.
Great. Thank you, Andrew. And if I could ask for the evaluation not to be up on the screen quite yet.
Sorry, I wasn't sure what to do with it. I'll end the light show.
You can look at my scribbles for a little longer.
We could probably just stop sharing the screen for a minute, Denise, and we just go to the participants, because we're going to have the kind of panel discussion or questions, if you like. And yes, thank you, Andrew, and great job. You did use up all the time the others hadn't used and a little bit more, so well done on that. Someone that's more like me than those other two that finished on time. So that was great. So I'm just going to welcome, that was fantastic, 3 really great presentations, all on something slightly different, but you can see the interconnections between them. And I'm going to hand over now to Barb, because she's been getting all the questions that have been asked, and we'll open up the floor. So Barb, I think you're going to facilitate the questions and get panel members to answer, so go for it.
Thanks, Denise. Thanks very much. And thank you to Denise, Linda and Edgar. They were great presentations. And welcome to everyone online. So we've got the first question, and this really is just an open discussion. But the first question is for you, Denise. Can you share with us any unexpected outcomes or surprises with your work in the person-centered framework with the new grads?
Can you hear me okay?
Yes.
Yeah, I think one of the unexpected ones, it wasn't with the new grads, but it was more with the facilitators that came from UOW, because a lot of my facilitators had gone off to you know, ICU and stuff like that. Was really struggling to find enough people to do it, and UOW staff came in and helped me. What they found is a real connection to the new graduates, and the new graduates also felt a connection back to them because they had already had prior relationships. And one particular group had someone quite high up in the university, and they actually saw that person as a person. And they really not changed their thoughts about that person, but were quite humbled by how lovely they were to them. And they were one of the really person-centered people facilitators. So I think, and also the connection that they felt through the supervision for supervisors, they felt really connected to high-level clinicians here at ISHLHD. And I think that was something that I hadn't really thought would happen.
Thanks, Denise. Linda, sorry. This is one for you. When you look at the birth environments, are you looking at all the other birth environments?
Yep. My focus is just on caesarean section births The theories that you know, I'm using very much compare the different, you know, they focus on a normal physiological labour and birth, but this is really, the focus is on caesarean sections, because that's the area that I saw the issues, that women, you know, trauma was increased when they were separated from their baby at birth, and that keeping the mother and baby together is one way to reduce trauma, keep the woman as that central person in her birth rather than a surgical procedure.
And Linda, could you just share a snippet of what you've been finding out? Because I think you've been finding out some really interesting.
Yes, so I've analysed half of my participants so far. There's a lot of very angry women. There's this has a huge impact on the relationship that they have with their partner and with their baby. And, you know, I know research says that women remember their birth experience for the rest of their life. And, you know, there's studies that have looked at 20 years after their birth, how that's impacted it. But these women, some of them are 5, 6, up to 10 years beyond their birth, and they remember the little things that people said to them, little things that people did to them, both good and bad. Unfortunately, the people who were very inspired to speak with me, there was a lot of bad. These were births all within Australia, not within just the Illawarra Shoalhaven local health district. But yeah, anger is probably the thing that's come out the most, and it's been because somebody has taken their baby away from them, and they didn't want their baby taken away. They didn't get to see their baby naked, or the first view that they had of their baby was their genitals. So the baby would be held up over the top of the surgical screen, bottom down, and they would see their genitals. So one woman didn't even recognise the genitals of her baby because she was a little girl and she didn't realise that the labia on little girls could be swollen, so she still didn't know whether she'd had a boy or a girl. And then the baby was taken away, and then they may not see them for many hours after that. And they don't get to look at them, check them, count their fingers and toes, and, you know, make that initial connection with their baby.
Thank you, Linda. I'll go to you now, Andrew. We've got a question for you. How does the coach instill positivity and hope in the coaching conversation?
So I think what we found really with hope, and there's two kind of views of it within the theoretical kind of framework we try to promote, is that being solution focused is focusing on the future and different pathways to similar goals. So a bit like the classic example when people want to walk, and the idea that we fear that we kind of encouraging people for things that they can't do. There's certainly different ways of getting around, and what will that look like for that person in the future. And I think also from our program, introducing people to having positive stories about having a future with disability enabled the clinicians to see that there's a way of looking forward about disability that isn't all negative, which often I think the social view of disability is that having a stroke, spinal injury or brain injury is a catastrophe, and this the kind of concept of tragedy is associated with disability. So tying that together with the hope theory, which gives this sense that there are multiple pathways, and really what you need is a sense that you're going to be able to achieve your future desired picture of life. Trying to bring together that loss of biography, because often people's future is their image of the future is completely disrupted by a significant acquired disability like stroke or spinal injury.
Thanks, Andrew. Did you see any of the impacts on the team?
Yeah, it was what was probably not disclosed in this. Was very much a multidisciplinary program. So the workshop program was massively contributed to by the presence of allied health and our medical director in the second cohort. And I think that made the program so much more rich. Nurses need to be amongst others, I think, to gather what other views of this work is, and I think we learned a lot from each other. And there's obviously, in addition to those people who've experienced Nicholas Yu's coaching program, quite a few of the participants of this program gone on to coaching-like programs and using coaching within their practice. Each patient currently on our rehab unit gets assigned a coach as part of the care. Hoping that our coaching framework is solution focused and strengths based. but that's still a work in progress. I think things are cycle within our own work.
Thank you. Denise, now going to you. Did you see a difference, what it made possible with the grad starts and with the clinical supervision? What did it make possible in the clinical environment? Was there anything that was observed or even that we could relate back to outcomes?
Yeah, so can you hear me okay?
Yes.
Yeah, so at the moment I'm analysing, we did see some changes in the person-centred practice inventory, but when Val and I and Tracy started to look at that, what we found is the people who came to supervision actually had a higher PCPI score at the beginning. So whether they're more motivated, but there's definitely a slight difference. But just through I'm so glad I did a mixed methods study and actually got their feedback, because they started to tell me about little person-centred moments, like the little capture about they discussed end-of-life care. So they went away with a bank of ideas that perhaps they couldn't use on that day or in the next week. But when things came up, like aggressive patients, about trying to connect with them as people, the way they connected with other people, they actually challenged some of the staff and their unperson-centeredness. Yeah. So it gave them confidence to do that. So these are the little gems that I'm finding at the moment. And I'm sorry I couldn't present them because I'm just trying to make sense of them at the moment. But definitely the ones that came and where the facilitator purely focused on the person-centered aspect of that. Yes, I think, and we only did that in 6 months. So I feel if we could have put it in as a longer programme, we would have been actually able to see more.
Great. So do you see this expanding beyond the grad starts?
Yeah, so because of COVID, we haven't had any clinical supervision training for nearly 2 years, and we haven't been able to run our masterclasses for our clinical supervisors. But now, well, I'm hoping that things will settle down a little bit. We've got much more focused on and able to do things on Skype and Zoom, which we hadn't done before. So I'm really hoping to be able to run a masterclass for our supervisors, and then when we do our new training, we will be pulling in the person-centered framework to that.
That's wonderful. Thank you. Linda, I think I'll finish off with you. How are we going for time, Val? Where is she?
I didn't time keep this bit, Barb. I thought you could do that yourself, but we're at 3:20, so we should be wrapping up and putting the next screen up with the evaluation in a minute. Yeah.
Just one last question, and we'll finish off with Linda. Linda, what impact do you see the use of person-centered language in care?
Sorry, could you repeat that again? You're a little bit stilted.
What impact does the use of language, particularly around person-centered care and woman-centered care in your case, what impact does it have in the delivery of our care?
Yeah, so I think it keeps reminding us, so if we keep even just saying this, you know, is this woman-centered or is this patient-centered, it keeps reminding us to come back away from us as the healthcare providers and back to the woman, the patient that's in front of us. And, you know, that helps us to accept that sometimes they're not going to agree with what we say or what we recommend, and that it's okay for them to say no, and, you know, providing choices for them to choose between options, and even then they may decline those options that we provide them. But I think we need to see that the power is with the patient or with the woman. It is us, even though we've got our badges and our uniforms, the power is with the person that we are caring for.
Totally agree, and it is all around the languages and creating that shared language. So we are going to conclude now. Thank you to the panel, and thank you for everybody out there that have asked all the questions. Denise will go to the evaluation. So that does conclude our whole series, which is very exciting, and we'll have another one coming to you shortly. But
I'll just flick to the end, sorry.
That's okay. So if you could just zoom the QR code that will take you to the evaluation.
Is that okay?
Yes.
Yes, thank
and
you.
we want to hear from you about what you would like to see in some of our future masterclasses. And I'll hand back over to Denise. I'm into Val, sorry.
Well, Denise and I are a bit interchangeable, with similar accents. So I just wanted to say thank you to everyone who came on and listened. There were 3 excellent presentations. I really enjoyed listening to them, and I'm sure you did as well. You will get sent out the link to if you've registered for the session today, you will be sent out the link. You will get the evaluation sent out as well. And we really appreciate if you can complete it, because it just helps us think about what additional things that we can put in place that helps meet the needs of each of you. And so I just think, and congratulations to all our presenters today. We look forward to the next masterclass, and hopefully we've got someone equally as fabulous to come and present another aspect of person-centered care, research, practice, learning, teaching, or whatever it is. So thank you everyone for attending. Have a great rest of day, and each of those presenters can now have a sit back and congratulate themselves, but not you two for too long, Andrew, because you're due in supervision in I think 5 minutes time.
Well, just to let people know that the QR code, they can go straight into the evaluation just now,
Yes,
if they want to. Yeah, absolutely, or you can get it in the link. Absolutely. So we'll leave that up there for a few minutes so people can scan that, or it will be sent to you. And if you haven't registered for today's session but you want a copy of the talk, if you just let Barb or Sue know, they will ensure that you get that talk. So well done everybody, and I'm going to sign off now so I get ready for my supervision with Andrew.
Thanks, Val.
Thank you all soon.
Thank you.
Bye-bye.
wonderful.
Bye.
Thank you, everybody.